Hello students. So today we are going to see another topic of spondylolysis, that is the lumbar spondylolysis. Last few classes we have seen different conditions which are interrelated in the spinal column, like starting from the disc prolapse, herniated discs, lumbar canal stenosis or the spinal canal stenosis, spondylitis, spondylolisthesis, and then spondylosis, cervical and lumbar. So let us see what is spondylolysis, and it is mainly seen in the lumbar area. So it is an unilateral or bilateral bony defect in the pars interarticularis or the isthmus of the vertebra, what we call the isthmus of the vertebra. The term derives from the Greek word spondylos, means vertebra, and lysis means a defect. So it can cause the defect can cause a slipping of the vertebra, in which case the term spondylolytic spondylolisthesis is used. This condition is a bit different process than spondylosis, because spondylosis is degenerative, that we have discussed already, while spondylitis is inflammatory, where there is a itis, inflammation. But spondylolysis is something incomplete development or an formation of the connecting part of the vertebra, that is the pars interarticularis. So if you see the clinical 11 anatomy, the last few classes we have already seen the types of vertebra, the vertebra structures, how it is designed, and what are the parts of the vertebra. So we will not go again in much into details. You can see in this picture a vertebral body and a bony ring or arches which protects the spinal cord. This arch is formed by the two pedicles which attach to the dorsal side by the two lamina which complete the arch. The area between the pedicle and the lamina is called the pars interarticularis, which is an important part in this condition and is in fact the weakest part of the arcus. And if that is defective or if there is a break, it causes spondylolysis. If you see the etiology, it affects 3 to 6% of the population, and it appears in the first or second decade of life. The frequency increases with age until 20 years. However, no change in prevalence with increasing age from 20 to 80. Men are affected twice as often as women if you see the male-female ratio. There is a possible of genetic tendency for people with lower cortical bone density at the pars interarticularis. There is increased prevalence in specific ethnic, sports and family groups. Spondylolysis occurs frequently in the young athletic population. So those who are active in sports, like for gymnasts, for football players, cricketers, swimmers, divers, weightlifters, wrestlers, and it is considered to be caused by a stress fracture that results from the mechanical stress at the pars interarticularis. These stress fractures occur due to repetitive load and stress over a long period of time and rather being caused by a single traumatic event. The stress distribution at the pars interarticularis is the highest in extension and rotation movements, and it occurs at L5 80 to 95% due to repetitive hyperextension, which increases the contact between the caudal edge of the inferior articular facet of the L4 and the pars interarticularis at the L5. Here just an X-ray to show spondylolysis. Here you can see the defect, the arrow here, you can see the defect in the pars interarticularis, and here you can see There, if you see the oblique view, again, this is the Scotty dog. You can see the break in the neck of the dog. Pathophysiology, it is a bony defect or a fracture, as I said, within the pars, and the majority of spondylolysis occurs in the lumbar. However, it can also be seen in cervical vertebra. The lumbar vertebra consists of a body, pedicle, lamina, pars, transverse process, spinous, superior inferior articular facets, and which form joints that link the vertebra together. So when examining the vertebra, the pars is the bony segment between the superior and the inferior articular facets that we have already discussed before, and it is located anterior to the lamina and posterior to the pedicle. So separation of the pars occurs when spondylolysis is present in the spinal column. It is typically caused, as I said, by stress fracture of the bone, and it is common in adolescents who are overtrained in activities, vulnerable to fracture during spinal extension, especially combined rotation, or when experiencing a force during a landing. The stress fracture most commonly occurs at the concave lumbar spine transitions to the convex sacrum at L5S1. Significant number of individuals with spondylolysis will develop spondylolisthesis, which is true for 50 to 81% of this population. What are the characteristics? It is mostly asymptomatic. If there are any symptoms, they often have the following characteristics. Pain is gradual or acute after intense athletic activity. Possible history of local trauma. Intense pain restricts the activities of daily living or sporting performance. It becomes aggravated after a stressful event. Rest usually relieves the symptoms, and the specific symptoms depend on the region of the spine that is affected. Lumbar spondylosis will show other symptoms than thoracic or cervical. Symptoms for lumbar area especially are the back pain with radiation to the buttock or proximal lower limb. Then you have the symptoms can increase with movements, especially lumbar extension or rotation. Children under 13 show tenderness or pain on extension and can present a postural deformity or an abnormal gait pattern. And there will be pain throughout the lumbar range of movement, unilateral low back pain that radiates to the buttocks or legs. It can be acute, can restrict daily activities, worsens after an strenuous activity, aggravated with lumbar hyperextension. Pain on completion of the Stork test, that is placed in hyperextension and rotation, excessive lordotic posture, unilateral tenderness and palpation, and the Scotty dog fracture, as I have mentioned you in the diagnostic imaging. A lot of other conditions can occur for the in the lower back area and lumbar area. So we have to do the differential diagnosis starting from the disc herniation, and then discogenic pain syndrome, facet joint syndrome, acute bony injury, sprain, strain, spondylolisthesis, myofascial pain in athletes, sacroiliac joint injury, lumbar radiculopathy, and then osteoid osteoma, osteomyelitis, spinal stenosis. Diagnostic procedures, mainly the golden standard for diagnosis of spondylosis is the combination of SPECT and the computed CT. So when a pars fracture is present, CT can clearly visualize the spondylolysis. On axial CT scan, the neural arch should be closed and continuous at the level of the pedicles. When there is a pars defect, there is discontinuity at this level of the neural arch. So sagittal CT image differentiates better between a pars defect and the facet joint and are also most accurate in showing incomplete fractures. And MRI also shows promising results in detecting spondylolysis but can be also used to determine the state of the disc above and below the affected vertebra. Most common findings of lumbar spondylosis are hyperlordotic posture and low back pain during lumbar extension. The Michaelis test, or we call it as a unilateral extension test, can be performed to confirm the diagnosis. Patient performs hyperextension of the lumbar spine while standing on one leg. In a positive test, pain is reproduced, and unilateral lesions often produce pain when standing on the ipsilateral leg. So you can please type this link in the YouTube and watch the video of the test. Neurologic exam is usually normal, but neurogenic symptoms can arise if the condition progresses to spondylolisthesis. X-rays are also very important and it is easily accessible for the patients. The radiation is more attenuated, absorbed by the denser tissues of the body, that is bone, than the softer tissues, for example muscles, organs, etc., creating a picture composed of shades of gray ranging from white to black. A vertebra with a fracture or defect of the parts will have a dark mark through the region of the bone. Since it is difficult to see on AP, X-ray view of an oblique X-ray of the lumbar spine can easily identify the spondylolysis. Another method is the bone scintigraphy, showing black marks where pelvic bone damage has been occurred. You can see in this picture, bone scintigraphy showing black marks where pelvic bone damage has occurred, and it involves the injection of a small amount of radioactive tracer into the bloodstream. This tracer decays and emits radioactive energy which can be detected by a special camera. The camera produces a black and a white image, whereas areas shown as dark black indicate bone damage of some kind. So if there is a black spot in the lumbar vertebra, this indicates the damage and potentially spondylolysis. If the test is positive, a CT scan is usually ordered to confirm the spondylolysis. Then CT scan, as I said, this is also one of the methods, and it produces more image than an X-ray. That is the advantage. Multiple image produce cross-sectional views not possible within the X-ray, allows the physician or radiologist to examine the images from many more angles than the X-ray allows. So for this reason, CT is accurate in detecting spondylolysis than an X-ray, and bone scintigraphy combined with CT is considered the gold standard, which means that is at best detecting spondylolysis. Bone scintigraphy combined with CT. MRI is a new technique to diagnose spondylolysis and is favorable for a few reasons. That is more accurate and also does not use radiation. It uses powerful magnets and radio frequencies to produce very detailed images of many different densities of tissue, including bone and soft tissue. Now, coming to the management. Medical management conservative treatment is usually sufficient to treat the symptomatic spondylolysis and aims to reduce the pain and facilitate healing process. The possible features of conservative treatment are non-steroidal anti-inflammatory drugs to relieve the pain, cessation of aggravating sporting activities, use of a brace, spinal brace to prevent motion, add the injured parts and allow bony repair, physiotherapy. Severe pain is present, progression to spondylolisthesis occurs which needs to be prevented, so surgical treatment in that cases may be required. Now, physiotherapy in spondylolysis has multiple goals. So, as we as physios have an important role to play in the rehab or the treatment of these patients, facilitating the healing process by promoting additional blood flow and thus healing of the affected parts. This can be accomplished by isometric contractions of the surrounding muscles, avoiding aggravating activities or turning into a chronic state by handling underlying causes like hypermobility, hyperextension in specific sports such as wrestling or skating, optimization of physical function, global and specific strengthening exercise to reduce pain, to promote normal movement patterns. So a rehab program should progress in 4 stages to control pain and inflammation. Taking stress off the injured area allows physiological healing process to take place. Therefore, it may be necessary to avoid rotational sharing forces and extension movements by a temporary cessation of sports activities or wearing a brace, which reduces pain intensity and functional disability levels. Now, deep abdominal core contraction exercises. The aim of these exercises is to train the muscles surrounding the lumbar spine, which provides stability, that is the core strengthening. It results, spondylolysis results in a spinal instability and disrupts the patterns of co-recruitment between the muscle synergies. Specifically, The local muscles that attach directly to the spine are affected, that is the lumbar multifidus and the transverse abdominis, that is the core muscles, play a direct role in stabilizing the lumbar spine. Instead, the local muscles in individuals with spondylolysis are vulnerable to dysfunction, resulting in abnormal spine stability causing chronic low back pain. So to compensate, the large torque producing global muscles are used to stabilize the spine. So in a study, patients are taught to train the co-contractions of deep abdominal muscles and lumbar multifidus in static postures, functional tasks, and aerobic activities. This technique was shown to reduce pain, and functional disability also was reduced when compared to other conservative treatments. These results also had a long-term effect in reducing levels of pain and functional disability. This is because motor programming eventually become automatic and conscious control was no longer needed to contract the deep abdominal muscles during activities. Activity restriction, as I said, is advised for a short period of time once the patient becomes symptomatic, followed by a guided physiotherapy program. There should be restriction of heavy lifting, excessive bending, twisting, and avoidance of any work, recreational activities, or participation in sports that causes stress to the lumbar spine. Activity restriction can help eliminate and control a patient's symptoms so they are able to resume their normal activities. Another thing I mentioned is the lumbar bracing, that is the anti-lordotic lumbosacral brace known as the Boston brace. This is used to control and limit the spinal movement, thereby reducing the stress on the injured spinal segment. Bracing immobilizes the spine in a flexed position for a short period to allow healing of the bony defect in the pars interarticularis. An antilordotic brace commonly utilizes a plastic component that is contoured to closely fit the body. Antilordotic bracing subsequently reduces the athlete's symptoms by decreasing the amount of stress on the low back and allows a prompt return to sports for athletes. Typically, it is utilized for 6 to 12 weeks. Then strengthening and flexibility programs, as the paraspinal muscles will go for spasms and the hamstring tightness are very much often seen in patients with spondylolysis. Stretching exercises can be added to the rehabilitation program. Flexibility training is useful in patients with hypomobility of the spine. A global strengthening program should be started with can include specific back strengthening exercises. Stabilization techniques, including activation of transverse abdominis and other core stabilizer muscles, have to be shown decrease pain in some researches. This section includes education in postural training, evidence suggesting that specific trunk stabilizing exercise are beneficial for spondylolysis. Functional movement. The main goal of physiotherapy is to increase functional abilities through a home exercise program. As soon as the primary pain decreases, patients have to be encouraged to resume activities as tolerated. Now, if the conservative management is not working or we fail to, then another option we have to go is the surgical management. Then most patients with spondylolysis do not require surgery, but if the symptoms are not relieved, then the condition progress to the higher grade called the spondylolisthesis, where patients may require surgery. So two types mainly. Already we have discussed spondylolisthesis in my previous class. Kind of same surgical management, that is spinal fusion, laminectomy, laminoplasty. The procedure fusion is recommended when a set of vertebra becomes loose, unstable. So the surgeon joins two or more vertebra together with the use of metal rods, screws, and bone grafts. Bone grafts complete their fusion in 4 to 8 months following surgery, securing the spine in the correct position. The procedure the procedure is also used to treat spinal instability, fractures in the lumbar spine, and severe degenerative disc diseases also. The process is really non-invasive, performed through small incisions, and has a high success rate. Another method is the laminectomy surgical procedure, often performed when spinal stenosis occurs in conjunction with spondylolysis. So the procedure surgically removes part of the lamina from the bony ring of the vertebra to reduce the pressure on the spinal cord. So the laminectomy is commonly performed on the vertebra in the lower back and in the neck. So here I have given the pictures of few good articles published in good journals. So you can see here, this is the title: use of one-legged extension hyperextension test and MRI in the diagnosis of active spondylolysis. So you can go through these in the Google and you can read the article. Another review article, that is the lumbar spondylolysis, and they have reviewed this condition about the pathophysiology and the biomechanics, how it is altered and how it happens, and how it is responsible for the low back pain, what are the diagnostic procedures. So this is one more article: suspecting lumbar spondylolysis in adolescent low back pain. So spondylolysis is commonly seen in the athletic adolescent and pre-adolescent. Common that primary care practitioners should be familiar with its frequency and the progression from pars stretch fracture to spondylolysis and to ultimately spondylolisthesis. So how it happens and what is the correlation is described in this article. Another one, spondylolysis and spondylolisthesis, very much interlinked. The spondylolysis, ultimately, if not treated, will go for the spondylolisthesis, prevalence and association with low back pain in the adult community-based population. So few of the references you can go through. So thank you students for viewing this video, and I hope this lecture on lumbar spondylolysis will give you a better idea of understanding, and if any doubts are there we can discuss, and thank you.